Assalamu alaikum dear doctors. In this video I am discussing about the child with kidney and lung problems, and the question is taken from RCPCH Theory and Science book, case number 41. So case 1 is telling that a 7-year-old boy presents to the emergency department with a 3-day history of worsening lethargy, dark urine and oliguria. His blood pressure is 128/91 mm of mercury and his urine dipstick shows mild proteinuria. On taking a further history, it becomes apparent that he had a throat infection 2 weeks ago requiring antibiotic treatment from his GP. So first question is asking us that which was the most likely cause of his throat infection. So the features present on the questions are telling that it is acute nephritis, and we know that the most common cause of throat infection in this case is that is group A streptococcus. So answer is C, that is group A streptococcus. Now question number 2. Given the most likely underlying diagnosis, are the following statement true or false? So diagnosis is there acute nephritis. A number ASOT is likely to be raised. Yes, ASOT is increase in acute nephritis. B, C4 is usually low. False. We know that C3 complement 3 is low and C4 is normal. Now number C, that is furosemide will usually lower the blood pressure in this context. Yes, that is true. Number D, renal biopsy is indicated if proteinuria persists at 4th month. This is false. We are seeing on the right side that is the indication of renal biopsy is indicated when creatinine persists, that is 6 weeks, low complement level 3 months and proteinuria 6 months. So renal biopsy is indicated, I am again repeating, creatinine 6 weeks high, low level complement 3 months and proteinuria, that is 6 months. Number E is treatment with penicillin will help reduce the proteinuria. The answer is false. Now we read the explanation. Our confusion will be much more clear. Let's start. The symptoms and signs described in both case 1 and case 2 are typical of acute nephritis. Acute nephritis is a glomerular injury that presents as acute kidney injury, kidney failure, oliguria, uremia and elevated creatinine, typically combined with hypertension, hematuria, edema and proteinuria. The hypertension is due to salt and water retention and hence often responds to treatment with the loop diuretic furosemide. See chapter 40. Hematuria can be microscopic or macroscopic and red cell casts are seen on urine microscopy. Proteinuria can reach nephrotic range more than 200 mg per millimole, although is usually not this high. It is therefore important that any patient presenting with symptoms and sign of acute kidney injury have a urine dipstick and have their blood pressure checked, ideally using a manual sphygmomanometer. It is also important to do a renal ultrasound scan. In cases of nephritis, the ultrasound scan will usually be normal, but is necessary to exclude other causes of hematuria and reduce renal function. In case 1, the recent sore throat makes a post-infectious cause of nephritis. Most likely, the commonest causative organism is group A beta hemolytic streptococcus, and the onset of symptom is usually typically 1 to 2 weeks after a throat infection or up to 6 weeks after a skin infection. Anti-streptolysin O titer ASOT is raised in the majority of the throat infection, although not after many skin infections. Remember that it is also positive in up to 20% of healthy children and so must be interpreted with caution. In addition to group A beta hemolytic streptococcus, there are a number of other organisms that is cause post-infectious glomerulonephritis. These include bacteria such as Staphylococcus aureus, E. coli, Streptococcus pneumonia, Mycobacterium pneumonia, Campylobacter salmonella and tuberculosis, as well as a certain virus such as Epstein-Barr virus, cytomegalovirus, herpes simplex virus, varicella zoster virus and hepatitis B/C, fungi such as Candida, Aspergillus and Histoplasmosis, and parasites such as malaria, Toxoplasmosis and Schistosomiasis. It is known that post-infectious nephritis is caused by an immunological process, although the exact mechanism is still not certain. The most supported theory is that of immunocomplex mediated glomerular damage, where antigenic determinants are found with a direct affinity for sites within the glomerular. In addition, glomerular bound antibodies serve as fixed antigen and immunocomplexes form, leading to complement fixation. This then trigger the classical complement pathway, leading to the production of additional inflammatory mediators and recruitment of inflammatory cells, which leads to glomerular damage. In post-streptococcal glomerulonephritis, treatment with penicillin is necessary to prevent spread of contact but does not alter the nephritis, the severity of which is variable but which typically resolves within 2 to 3 weeks. C3 complement 3 is usually low while C4 is usually normal. unlike the membranoproliferative glomerulonephritis, MPGN, SLE, and endocarditis. C3 returns to normal by 6 to 8 weeks. Renal biopsy is not indicated unless either the creatinine remains abnormal at 6 weeks, the low C3 proteins beyond 3 months, and the proteinuria persists beyond 6 months. Microscopic hematuria can sometimes persist for 1 to 2 years, however, is not of long-term clinical significance. The long-term prognosis for children and post-infectious glomerulonephritis is excellent, with only 1% going on to develop chronic kidney disease. Please do subscribe and share my channel, everyone. Thank you.